Good morning, good afternoon. I'm Katherine Marshall, speaking from Washington, D.C. Welcome to this webinar on a critically important topic at the global level, which is the relationship between the COVID crisis and the HIV/AIDS pandemic. We're recording this session. The video will be available later, and we welcome you to raise questions in the Q&A box at the bottom of your screen. This is one of a continuing series of webinars that reflects a special partnership that began. We launched it in early March to track the COVID pandemic. It involves the Joint Learning Initiative on faith and local communities, the World Faiths Development Dialogue, and the Berkley Center at Georgetown University. So welcome to our wonderful panel. We want today to address some of the critical questions that are involved in the HIV/AIDS pandemic, but very much in the context of the emergency that we are all living, which is the COVID emergency. And Dave Barstow is a passionate advocate. I think he's dedicated his life in many ways to the HIV/AIDS cause and pandemic, and has worked in a remarkable way to put together a strategic framework on the roles of religious entities in bringing the HIV/AIDS pandemic to a real close during the decade that lies ahead. And then all of a sudden, the COVID pandemic appeared. But Dave, maybe you could start us off with a short, because it's such an extensive process you've run, a short description of the strategic exercise that you've led and where it now stands in the global setting.
Sure, thank you, Katherine. This is actually a great opportunity to merge together two things the Berkley Center has been doing: the COVID response that Katherine was just talking about, plus an HIV response analysis that really began about a year ago when we had a live in-person meeting at the Berkley Center. And one conclusion was that with the global target of ending the HIV epidemic by 2030, it would be important to have a careful strategic analysis of the role that faith should play in achieving that goal. And so we assembled a group of about 30 people, all committed activists, I guess, like I am. And over the first 6 months of this year, put together a strategic plan that is now available on the Berkley website. The timing was interesting because we began before there was any sign of anything like the COVID pandemic, and we ended when the COVID pandemic had tragic consequences around the world. So our question was, well, what do we do with this thing that we were already underway developing? And we decided to finish the development with respect to HIV and then take opportunities like this to see how it should be adjusted in the COVID-19 context.
Good, thank you, thank you. It's really quite a remarkable exercise with surveys and very probing questions that have been asked. And of course, now we need to keep it very much under review as the realities of global events unfold. Bios of all the participants today are on the website, so I'm not going to go into detail on the qualifications, but John Blevins is a colleague who is, I think, one of the few people who is as immersed in the HIV/AIDS crisis as in the COVID crisis, from his base at Emory University, but working with the Centers for Disease Control, as well as looking very much at the religious dimensions. So how do you see this duel, John? What is happening? We are hearing unsettling reports that HIV/AIDS programs are suffering in the areas where they're critical. What is the duel, and what do we do about it?
Yeah, it's a great question. And thank you, Katherine. Thank you, Dave. And I'm glad to be here and to be with the other panelists as well. I think we're in the very first months of the COVID response and don't yet know how this is going to play out. In the short term, in the midst of what we're in, we know that there's been this tremendous disruption to the systems to provide services to people with HIV. People living with HIV have migrated back to upcountry rural homes in some places if they were able to. They've left urban areas in lower and middle income countries where they no longer had access to a daily job and moved back in with extended family systems and units for livelihood, just to maintain their health. In doing that, they have left the clinical systems of care, they left the psychosocial systems of care that are really essential for keeping people retained, and they potentially provide a context for new disease transmission based on risk behaviors happening back in those places. So I think COVID has had a real, excuse me, has had an immediate impact in regard to this disruption of the systems that had been built for the last 15 years in the global context through PEPFAR and the Global Fund. And we don't know how that's going to play out yet. I think that the questions about how to make sure that those systems that were built can stay in place and be robust is still in front of us. And it's going to be really important not just to think about the structures of them, but to advocate for funding and shifting priorities so that we can pivot to address what those kind of cultural changes and structural changes are putting in front of us.
Could you comment briefly on how you see the religious engagement in this tension, but also in the hopes that lie ahead?
Yeah, I mean, for me, I think that the way that local faith communities, local masjid congregations, temples, mosques could be resources, as well as faith-based organizations and faith-based health systems, particularly in sub-Saharan Africa, is that they are trusted, they have longevity, they have sustainability, and they don't exist solely on the basis of funding. They exist with a deeper mission that's not necessarily tied to a funding structure. Now that's complicated because I think funding systems and structures in the PEPFAR era have shifted that in some ways, both building capacity, but also increasing a reliance on external funding sources. So there's the question of sustainability and trust that I think is going to be real important. The challenges is, and these are challenges that HIV had for 30 years and still has, that HIV has had for 40 years now, that we can learn some lessons from, is to make sure that faith-based responses learn from the very hard lessons learned out of the HIV response of nothing about us without us, and that local communities most impacted have to be at the table and to have a leading voice in articulating what a response looks like and what can be sustainable by those communities. In the HIV context, that was complicated because religion would sometimes be one of the drivers of keeping some of those people actually away from the table. And so that's been a real challenge and a hard lesson to learn, and a structural kind of having to build a structure to do that with HIV. In the COVID context, I think the parallel or an analogy related to that is to make sure that the ways that the virus is impacting and the outbreak is impacting lower and middle income countries around the world reflects a public health response. I think a lot of our initial community level responses reflected a bias toward Western industrialized nations and a kind of household and community structure that just didn't reflect most people in the world. And we have to make sure that we develop prevention and mitigation structures and approaches for COVID that can, that do reflect the reality of the way most people live their daily lives. At the point in time where a vaccine is available, the question of vaccine rollout, both in terms of capacity and the question of how immunization efforts can build a message of trust is going to be really critical, and faith-based organizations and faith communities could play a role in that regard.
Those are very important comments. The idea of nothing about us without us is a theme that I think we'll return to. Pam Price is with an important organization with an interesting name, Balm and Gilead, and has been involved in these issues for a long time. How do you see the situation unfolding now?
Yes, and thanks again to Dave and to John and to you, Katherine, again for putting this together. I think even just the work that you've already previously done and getting all of us as panelists and us as organizations really in a position to strategically think about these things. And I agree with a lot of what John just said. There are so many parallels, I think, both for the positive as well as for the negative or things that we still have to work on. So, as an organization for 32 years now, the Balm has been in this space of saying, how do we get our faith community? How do we get our religious institutions to see themselves as influencers, to see themselves as a part of, the mechanisms and systems that we need in order to combat HIV? We're now having those same conversations around COVID-19. Just as John alluded to, churches who had been able to offer, whether it was social support or whether it was actually, testing and other kind of direct services, those also kind of, went away. The psychosocial, I think, element that our churches played for a lot of our communities was also one when we did some small surveying of our networks that was huge. They're just, these were safe and trusted spaces, as John had mentioned, that were no longer open. They were no longer accessible. And so, the technology divide became greater in terms of who has access. We found so many individuals who broadband became an issue. You didn't have enough devices in the home. Kids were, in March and April, kids were trying to finish out school. Parents were working from home or just lost jobs altogether. So there were a lot of the, I think, social economic things that great strides had been made in the conversations around HIV that we lost, some of that footing. And so those became barriers again, such as, financial barriers, access to care barriers, utilization. So even when services were being made available, as John mentioned, people had to relocate their families, whether it was for jobs or again, for other, reasons. And so I think COVID, presents an opportunity for us to see what is still needed in this space. I think definitely culturally. So when we think about faith, so how do we get them, I think, to step up? How do we better maximize the existing resources that they have? And how do we position them to be able to have these two conversations? Both COVID-19 and HIV have parallel underlying issues that we still need to address. I think there's still stigma and there is trust. The beauty of the faith community worldwide is that that's the one area I think we've always relied on, is that the mistrust is not as heavy as what we see in other institutions. And I think if we could get them to really find different ways to utilize the fact that they don't have that hurdle to jump through, so that they can now move forward with, more important, conversations around, again, who should be at the table. How do we, even within the faith community, broaden our diversity? How do we broaden our inclusivity? Because as John mentioned, there are tables that everyone within the faith space does not welcome. And we have to make sure with COVID that we don't make those same mistakes. I know Dr. Seal would say that we've got a beautiful, railroad track, if you will, in terms of the work the institutions like Berkeley and the Balm and Emory have been doing for 30, 40 plus years now. And I think we can see how can we use these mechanisms and use this existing railroad, if you will, as a way to now put COVID-19 on top of it, and to do it in a way that we can re-engage, we can create sustainability. Funding, I think, is still a challenge, because we've seen HIV funding and where, again, people were putting priorities, dwindle. And I think we need to now advocate and have our faith community advocate, not just for the funding, but I think also policy. So going back and saying, are there still some policy conversations that we need to have? Does the national or worldwide strategy to address HIV and now COVID, how do we expand those conversations and do it through, this kind of faith-based, mobilization and advocacy work?
Great. I like the analogy of the railroad, that we've built a railroad. We need to ride it and to follow it. Rainier Koeglenberg is sitting in South Africa, I think in Cape Town, and has been following the HIV/AIDS crisis for many years, and now is deeply immersed in thinking about COVID as well, and bringing religious communities. So Rainier, how do you see the current situation in South Africa? And I think this is one of the places where this duel is perhaps most vividly played out of all countries in the world.
Thank you, Katherine. You said in the beginning, there's a lot of complexities. In our context, I have to rephrase the theme. We officially sit with TB as the #1 cause of death. So it's not only HIV and COVID, it's also 60% of people that has HIV has also TB in South Africa, which makes it much harder. And in addition to that, we have a severe economic crisis that started before COVID on top of it. So South Africa is the epicenter of HIV in the world. We account for 20% of all infections in the world. And we have a program of $1.5 billion annually. And still there are huge gaps. We have 200,000 new infections every year, and between 2 and 3 million people are not on treatment. So we really have a steep battle to get more people on treatment, to be more effective in prevention programs. So given that context, probably the most severe impact of COVID was the economic ruin of South Africa because of a very hard and long lockdown. I have to raise this because I want to say something about the negative and positive effects of COVID. Some of the negative effects is the same as what John and Pam referred to. There has been a redirection of resources to emergency services to deal with COVID. There has been an interruption of ARTs in some provinces up to 20% in 3 months. Now, if you look at the modeling of the World Health Organization for sub-Saharan South Africa, it could be a huge number of additional deaths in the year or two to come. But the severe economic impact meant that 3 million people lost their jobs in over a 3-month period, the second quarter of this year. 2 million of that were women-headed households that had informal work. And immediately you had a food security crisis. So even if you want to speak today about HIV or COVID, that's not the #1 priority in South Africa. The priority is, where do you get food for your family? It overrides everything else. And if you link to that our economic crisis, South Africa is almost on a fiscal cliff. We give the tax revenue, because of the drop in economic activity, has taken a big knock, and South Africa is overspending every day, and we're borrowing every day, and we're at the end almost of the line to get public spending under control. So the economic impact of COVID-19 is probably the most severe impact, whereas the health issues, of course, are equally important. I say this because it has an immediate impact on children's health. we have a large problem of young children that face hunger and danger of stunting. And COVID has also impacted on the income of churches. And churches deliver a lot of care programs, but with the lack of income, because we can't have normal church meetings, there was a severe drop in the income of churches themselves and other faith communities. So these are very negative aspects. It might sound a contradiction, but there have been some positive aspects, because COVID forced us in some ways to rethink what we're doing in our health system. And on the national level, the health minister have increased a lot of capacity, appointed new staff, developed new information system, increase the quality of data in the public health system. These are all positive things that were fast-tracked because of COVID. At the same time, in some of the provinces, they changed the model of public health to try and keep people away from clinics and to do more work in communities, because clinics was seen as a risk factor. Still today, people avoid clinics. So we have learned from that even the messaging around COVID can be positive, because you have to take responsibility for your own health. And because there's not a sexual undertone in COVID, it affects everybody, regardless of your behavior or lifestyle. There's some lessons to learn from that, even dealing with HIV. So we've seen the negatives and we've seen the positives. I think I should stop there. I would like to comment on some of the strategy paper points, but I can do that later. Thank you.
Thank you. And I think the point that you're making about some of the broader lessons about health systems are critically important. Let's go back to Dave. Dave, there've been a lot of, there's been a major event, obviously the Global AIDS meeting, which was supposed to be in San Francisco and Oakland, but which of course took place online. And there is a meeting, interfaith meeting that's coming up soon. What are some of the major points that have come out of those discussions? And I would ask you, in all the work you've done on the strategic framework, what has surprised you? What did you not expect to find? What changed your view, if anything, as you went through the process? So 2 questions for you. And I do encourage people, we have 1 question already that I can see, and we'll turn to questions after this round. Dave.
There we go. The with respect to the conference coming up on September 22nd, 23rd, and 24th, I think the issues that we've been talking about are many of the same ones that we've already been talking about. There will be a session on the interplay between HIV and COVID. The theme of the conference is renewal and resilience. And I think that's an important one at this point in time. We're now 4 decades into the epidemic. We hope we're beginning the last decade, but it does take some resilience, and especially in the context that, for instance, the concept that Renier described, that things have gotten very complicated now. And in the midst of all that complexity and all that worry, we do need to find ways to renew and be self-reliant. For surprises, I think the biggest surprise was the commitment that everybody believes we need from the faith community, that we're not going to get to 2030, we're not going to end HIV, we're not going to control COVID without active, strong partnership from faith communities. The same thing that all of us have said already. And I think that the strategic analysis really, I mean, it was talked about as a faith analysis, but it certainly confirmed, I think, all of our expectations that it's the faith has an extremely important role to play, just as, again, as everybody's already described. I think one thing that has come out lately in the interplay between HIV and COVID is what Renier just described, and that is rethinking public health systems. I think certainly in the US, the inequities in the health system have become so blindingly obvious that it I hope will force us to rethink how we deal with public health. And by coincidence, yesterday, Winnie Byanyima, the executive director of UNAIDS, made a statement kind of about saying this as an opportunity that comes out of the interplay with COVID. She said, "This is a unique opportunity to reimagine systems for health. All eyes are on health systems and health care, with countries wanting to be better equipped to deal not only with COVID-19, but also to create healthier, more resilient societies. We can seize this opportunity by learning from HIV and from COVID-19 to make important changes to develop rights-based, equitable, people-centered systems for health." So, you know, I take that, I agree with her completely. It's an opportunity, just as Renier described. I hope we have the political will to take advantage of that opportunity.
Great. John, let me turn to you next on, and maybe we should focus on this broad question of health systems, which I know is a central concern for you. Maybe you can focus a bit on that internationally, you know, the SDG on universal health coverage, et cetera. And maybe Pam, I don't know if you're comfortable in taking this a bit closer to home to the United States. So maybe
Absolutely.
we can do that. So first, John.
And specifically about health systems.
Yeah.
Katherine. In regard to health systems and health services, whether that be HIV or COVID, in the global context, I do think that we now are a decade plus into recognizing that in places outside of Europe and North America, faith-based health providers, faith-based clinical systems are absolutely essential partners to national level governmental approaches to health needs, such as HIV and also in the context of COVID. And I think that those partnerships, the strategic partnerships between a governmental approach, a civil society approach beyond the faith-based system, and the contributions of the faith-based sector is clearly researched, and we now know just how substantial that is. That in Kenya, for example, about 30% of all HIV services in the country are clinical services, are provided by a faith-based health center, dispensary, hospital across the country. And in places with high disease burden, such as Nairobi, along the coast, those percentages are even higher. About 70% of pediatric HIV clinical care in Nairobi County is provided by a faith-based health provider. And so that's really an important structural element. The thing that I don't think we've done yet, and I think we're doing it, and I think COVID has revealed the need for it, is that concurrent with the idea of health system strengthening, that we have to develop more robust community systems that go alongside of and that provide more seamless linkages between clinical and psychosocial services that help in the context of HIV for retention in care, referral into treatment for those who test positive, particularly in a faith setting, in a testing event that's held in a local religious community. And that's the part that we're building, and we were beginning to really build it when COVID hit. The capacity to do that and to maximize that can also play a really important role in the COVID response. The other thing I would say about this question of systems gets back to Dave's question. I think that what Dave's response, I think that what COVID has just laid bare in a really dramatic way are large-scale macroeconomic, social movements and systems that are the primary drivers of inequities, of economic inequities, of social inequities, of health inequities. And it's laid it bare. And the pain of that is that we see the human cost in a very short-term immediate effect. The pain of it from the point of view of a public health response is that we recognize, despite all of our talking about the social determinants of health and thinking about social structural factors, is that we really don't know how to address those macro level systems and structures, and neither do faith-based organizations. The good news is that we are seeing that, and we've been confronted with it, and the social disruption we're seeing, whether that be through movements in the United States for calling for racial justice and racial equity, those are really important movements as justice movements on their own terms. They're also really important movements for helping us to understand the linkage between those macro structural forces and things like vulnerability to HIV infection or disease progression, vulnerability to COVID infection, and not having access to care, vulnerability to not being able to put food on your table, and that becoming more important than following the stay-at-home mandates and measures, as Rainier talked about. And those are the things that, from a public health perspective, we've seen. Our faith communities could play a role, and we have resources to play a role to articulate a theological vision that speaks to those principalities and powers, to use a specifically theological term. And we have to rekindle that prophetic voice in our religious systems to speak out in regard to those issues. And the good news is that that voice is never gone away. HIV was a point in time and an illness in which that voice was rekindled a generation ago. And we need to rekindle it today around these kinds of issues that are social, structural, systemic in nature.
Great. Pam, let me turn to you.
So in terms of, I think, yes, as we think here in the US, and what was so interesting about what John was just sharing, I think that in terms of how, or maybe the capacity that has been built to allow faith-based care to happen and be such a huge part of the healthcare system, I think in the US, that is, it hasn't made that big of a shift just yet. So that, again, having laid bare, I think the inability of our existing healthcare structures here in the United States, really does, not only paint the grim picture of how far we still need to go, but also, as Dave mentioned, maybe revisiting, the conversations that I know have taken place about how does public health and our healthcare infrastructure, how does it get better about having these community linkages? Because I think, again, as if we create or reimagine our existing public health and healthcare infrastructures, and we do it independent or separately from, as John mentioned, building up the community's capacity, building up the community's system, then I think we'll be right back, where we are, either with the next pandemic or even in just 10 years of not being where we possibly could have been. Because in the community is where the root causes of a lot of the social, systemic, societal things lie. That's where the biggest and greatest impact is felt, both physically, spiritually, mentally, emotionally. Our churches have been taxed now because of some of the social unrest to have a reckoning with its own role that it has played as an institution across the board, but also of saying, how do I continue to broker trust with systems that this community that I'm serving, is no longer, viable. There are these kind of, we're talking about dueling. These are these kind of internal, skirmishes and struggles, if you will, that, again, COVID has helped lay bare, and not just COVID, the structural racism, the structural biases that have long existed, and we are them come to the forefront of health discussions, which is a great thing. But I think that means that our conversations have to change. We have to shift who we're talking to. We have to shift what we're talking about, because I agree. And it's not just, healthcare, Rainier pointed out, our education systems, when economies and things, and you saw, okay, well, what about the mental aspect of no longer having these systems? And what about the food and nutrition aspect of it? We have to think about how do we get to it to where there's HIV or COVID-19, when these types of global issues happen, they are not disrupting people's access to food. They're not disrupting people's access to being able to still financially support themselves, addressing the wealth gap. So I think as we, reimagine what public health should look like and what healthcare in general should look like, I think we have to say, okay, it's got to run something that intersects, not just parallels, but it must intersect, I think, all of these different, cosms. It must intersect faith. It must intersect culture. Within the Black church, or just within church in general, there are still vulnerable individuals at risk who aren't even touched by our faith communities.
Great.
And so, making sure that we're kind of, touching, or identifying all of the true touch points to be able to address these and have both a grassroots, bottom up rebuild as well as a top down rebuild, to, reimagining the power dynamic, decision making at all, levels, state, national, and local.
Great. Rainier, John described in some detail the ways in which the faith provision and involvement works in Kenya. And I know that in South Africa, it's very different. So I'd be interested in hearing your comments about how churches and mosques and other traditions are actually involved. I know you, for example, worked a lot with mining companies and other areas, but how does the faith dimension really come in South Africa? Mute.
Thank you, Katherine. I want to start by referring to the strategy paper that you published and that Dave has done, because there's something important that I don't want to leave out of what we discuss. And that is the old conflict between what we confess and what we practice. We know that religion can be positive and negative and dangerous. And I don't want to let ourselves off the hook. And the nice thing about the strategy paper is it translates that into programs that you can measure what you're doing, because we still face that kind of conflict of confessing the unconditional love of God and dignity of all people. But empirical research show us this is not really what's happening at the level of local congregations. So our first challenge is to ourselves, not to the funders or anybody else. Coming back to systems, South Africa is different from many other African countries. We have a strong public health system. We've lost a lot of capacity of faith providers. Many church-based hospitals have closed in the last 15 years because of lack of funding mostly. But the problem in South Africa is not so much that we don't have a public health system. It's the fact that there's a big dichotomy between private healthcare for those that can afford it, and 90% of the population that can't afford private healthcare is dependent on public healthcare, which is in a crisis. So how do you bring the two together? Because we need both of them. And a specific, what the faith sector have been doing in South Africa is to try to partner with the public sector. We don't want a parallel system. We don't want faith health parallel to public health. We want the two to be, there should be synergy and cooperation. So there are agreements between some churches and the National Health Department to provide chronic medicine, ARTs, diabetic medicine, high blood pressure medicine. So people don't have to go to clinics, they can collect it at churches. There are conditions, but it's a formal framework. I think the biggest challenge for us in South Africa is to make, is to better synchronize government programs with what happens within our faith communities, especially at local level. South Africa has a very large community healthcare workers program. Many of them are funded by PEPFAR. It's still not enough. It's quite a costly element of our public health system. You know that in faith communities, we do the same work for much less money because most of them are volunteers. But there's no funding to coordinate that. And we need funding to support what faith communities do very well, very efficient, and do it mostly as volunteers. And that's what I saw at working with the mining companies who provided some funding for that, that you can actually, what we try to do is integrate our relief service, our food relief service, with collecting social medical data. So if people get food parcels, we can capture all the detail of vulnerable families in terms of children, people with chronic diseases, older people, young children. So we integrate all services because local faith communities know what's happening on family level, on ward level. But there's a lack of proper coordination. And it's not a sexy thing to fund for international donors. They see the big gaps in treatment. I would argue our biggest challenge is to complement official public health system and paid healthcare workers with a system of volunteer support by what churches do and local faith communities, because they have by far the best reach. They are trusted, like John has said. They are locally based, but they also need cost to cover some of the cost because they've also been hit hard, very hard by COVID. Mm-hmm. But for a fraction of the money, in the times when we implemented global fund grants, we always had fights with the technocrats because our unit cost for workers were much lower than the unit cost that they design in a grant. So they penalize you and say you're not spending the money. The reason why we were not spending the money is to avoid a conflict between volunteer workers and those paid with grants. So in some ways, I want just to highlight it. This is, of course, a question that you should answer in the context of every country because systems are different. But there's an extremely important role that international partners like PEPFAR, like USAID, etc., could play in terms of the leverage they've got. If I could get 1% of the money that the US government spends in South Africa, 1%, we could change this country around because they fund an enormous lot of faith response.
This message, I think, is a very critical one. And just turning to one of the questions, we have a few questions that have come in. Let's shift this a little bit, but what is happening with the actual supply chains for the HIV drugs? You mentioned that a little bit, but perhaps you have a comment on that and maybe John could pick up as well.
We had the unfortunate case that with the emergency funds that we received from IMF and others for COVID response, that there were massive fraud and corruption in South Africa. In only one province, 500 million rand was lost by service providers because they were not normal procurement measures. Because of the emergency, people were giving away contracts without due diligence checks, and there was really a lot of fraud. So good governance matter, especially when it comes to procurement, because we can't afford to have bad governance.
So that did result in some disruptions of
yes.
Supplies, yeah.
Yes.
John, do you want to amplify that?
The only thing I would add is that I do know that within the countries that I have some relationship with, in-country staff working both within the PEPFAR system and within the UNAIDS system. I don't know as many colleagues within global fund networks. Looking to address this issue is that the key question is capacity building on the supply chain and on the distribution from getting the antiretroviral to the health facility or to the dispensary and to the local community. So it's a pivot for a supply chain, building a supply chain and a pivot for distribution of antiretrovirals. That distribution also requires some way for clinical providers in places that may not have had as much of a high HIV disease burden, but are seeing new people who are living with HIV now in their local communities to provide care for them. And so there's a kind of concurrent need for providing for clinical education, clinical training, and capacity building in health facilities. One of the things that our organization, that Emory is doing along with colleagues in Kenya at St. Paul's University is to assess the capacity to leverage, strengthen, build, and mobilize local faith-based clinics in the counties that comprise the former Western province of Kenya, where HIV disease burden is high and where COVID has meant that the provision of HIV clinical care has been disrupted, to bring faith-based health facilities that are providing good clinical care in general, but not providing a lot of HIV services, to bring them to the table to be part of a coordinated HIV response. That's really important, and that's going to take a couple of years. And so what do we do in the interim? That's a huge question around building a more robust and nimble structural capacity, and that will take some time. And what do we do in the interim to help provide for people who are falling through the cracks as we build it? And I don't have an answer to that.
We have a couple of questions that touch on issues of commitment, mobilization, and I think coordination. And one aspect of that clearly is religious communities working together. And unfortunately, Aza Karam, who's the Secretary General of Religions for Peace, an important global interfaith organization, could not join us at the last minute today. But let me turn to Dave and see if you have any observations or pleas or insights on this question of working together, bringing the different threads together.
Yeah, thank you, Katherine. You asked before what surprised me. And I would say one other thing that came out of the strategy planning exercise, it wasn't a surprise so much as a confirmation of a hope. And that is that multiple religious traditions and believers of all sorts of faiths can work together quite well. And that by and large, the places where we agree and the things we want to do together are much, much broader than the few little things on the extremes where we might differ. And there was a quote I love from Reverend Pumzile Mabazela, who is the executive director of Interrela Plus in Johannesburg. So Renya, you may know Pumzile. She said, when religious communities agree on a common cause, they can successfully transcend the confines of their doctrines. And I thought that point was it's if we agree on what we're trying to do, then we can work very well together. And that played out in the strategy, especially at the national level, where our recommendation was to take an interfaith approach to national plans, to coordinate across faiths, and to have somewhat coordinated training plans. Capacity building, so that different local religious communities in the same community aren't battling with each other, but instead are working together.
Pam, you've focused, as I think every one of us has today, on the issues of the inequalities that the crisis has revealed so starkly, and that I think also are part of the story, the 40-year story of the HIV/AIDS pandemic as well, is that something that seems to affect everyone, in fact, affects different groups very differently. And you've also highlighted the links to the racial, the issues for the Black community. I don't know if you have any additional comments that you could offer to help people to think through how do we bring these different issues together? It's interesting to me that, you know, public health loves simplicity. Wash your hands, stay home. And yet the issues you're talking about are so complex and have so many different dimensions. How do we move forward?
Absolutely. And we've been given, been giving a lot of thought. We've actually been having some very candid and frank conversations with our various partners, whether that's, conversations around diabetes, even still with HIV and stuff that we'll be talking about as a part of USCA this year. And I think, one thing that I would definitely I don't want to miss that Rainier touched on is what you can do. I think when you put just a little extra emphasis, a little extra attention, a little extra funding in something that may seem small and trivial in terms of the people. Whether it's volunteers, community healthcare workers, for us, it's how do we better use our health ministry coordinators that we have hundreds of them across, the US, and we still have those are working in Africa as well. And so it's interesting because we were able across 6 states in the US to take and divert a few resources to actually put certified health coaches to be able to deliver a program that was not one that was designed or even created by the faith community, but it was, vetted, it's evidence-based, but we just put it in the hands of the people who we knew could carry it into these communities. And by doing so, these participants are doing, far, better than other participants in terms of, their physical activity, reducing their BMIs in terms of diabetes prevention. And so that's a model that we've been saying, one, can we replicate that in other areas that can connect HIV and COVID-19? And then I think, two, as we do that, because we are a Black-facing organization, our CEO is Black, I'm Black, we have, a predominantly African-American staff, our subject matter experts is where we bring in our diversity. And I think that lends itself to other institutions to do and mend the issues when it comes to the race and the cultural things. And I think to do that, we have to, as Rainier, we have to own up to, whether public health and faith has to own up to our own mistakes. I think, the religion has been used to enlighten and inspire, but it also has been used to oppress and enslave. And so we have to say, okay, well, how do we use it for the best purposes? How do we use it for the purpose that I think the vast majority of believe that it was designed for in terms of, religion? And then how on the faith, or on the public health side, how do we address 400 something years of where we have not earned the trust? We're asking for it, but we have to take a step back and figure out the ways to earn the trust. I think earning it is a way that we get to the poverty. We get to address food insecurities. We can address, whether it's the racial and police brutality that we're seeing. Those conversations have to be a part of larger, strategies. I think, how do we convene, the Balm has been convening small virtual town halls with churches, with their members, with the community. And we're just asking them, how are you doing? Before we come in and talk about what we can do and what we can recommend and suggest to do, we're just trying to check in to see where people are right now. Because there's a lot of, angst, there's a lot of hurt, there's a lot of trauma that is generational. And I think if we don't address that, we continue to have some of the behaviors that, will keep HIV at the forefront. It will keep HIV in a space that we can't, end it. And so bringing these voices together to look at, race and cultural things, I think should happen both in the church as well as outside of the church. I think public health and healthcare can look to use the church as the safe space to have it. Because it's, these are very difficult, things to own up to and then collectively collectively coming up with what are some of the solutions. And Dave hit it, hit the nail on the head, whether we're talking interfaith or we're talking about intergenerational or we're talking about across, cultures. We have way more in common than we do things that aren't in common. And everyone wants to have and live a quality life. Everyone wants good access to good care and to good providers. We all want access to good foods and a grocery store and, to a place to get active. We want our kids, to be safe. And so I don't think anybody can argue that that's not something we all want. I think, again, it's how do we find the common ground on what common solutions look like, so that it's not saying, okay, I think most of us have seen perhaps the, equity, equality, image to where you've got the 3 boxes and then you say, no. I would even go further. The fence doesn't need to be there. And so if we think about that image, how do we break down the fence? Yes, we're going to figure out that this group needs a little bit more of this groups need this group doesn't need anything. So can we use them? Can they become champions? Can we get them involved in supporting and creating boxes for the other populations that may need it? But I think we start by saying, let's break down the fence, and that fence, I think, is our silos. The fence is how do we increase and maximize funding and resources? And I think how do we bridge the gap between the things that we have, let kind of, fester perhaps underneath. And now that COVID-19 has kind of, again, laid that all bare and pulled the Band-Aid off, how do we really heal? I think that's, when we are having conversations, what keeps coming up is we want to heal. We want to heal, and we have to have good allyship. The Black church, the mosque, our temples, none of these faiths independently can fix these issues and these challenges. And so it has to be us coming together. And likewise, the African-American community, the Hispanic community, the white community, all of these communities, Asian, Native American, we're all here across the world. And so we have to say, okay, how do we, find the common ground and be able to come together with the solutions that, again, that are going to move us all forward, as opposed to move this group forward and then this group gets left behind?
Well, that's very inspirational to break down the fence to move forward. As we come to the end, I'm going to give the other 3 a minute, literally a minute, half a minute even. Dave, last word.
You're on mute.
We can do it, but we have to take the opportunity to do it.
John.
It is imperative that we develop theological frameworks, and we put those theological frameworks into action. Theological language tied to sound public health action to address the drivers of HIV, the drivers of COVID, the drivers of inequity, all up and down the causal chain, from local communities and grassroots level to the middle structures at regional and national levels, all the way up to global frameworks and perspectives. And we have examples of that and successes in that. We need to replicate them and reproduce them.
Bringing theology and public health much closer together. Renier, last word.
I agree with John. We have to develop a joint language. We have the same objectives. If I could add one thing, I often said we don't need more money in the world to make this work. If we can combine the objectives of the strategy paper with the UNAIDS paper that was released yesterday, we can do it. We have to be realistic. We simply have to spend the money smarter and better cooperate with one another.
I think there's a very strong common message here, which is a message of possibility, the feasibility, but also I think the idea of this prophetic vision of looking beyond the immediate issues of the HIV and the COVID pandemics and the tensions that we've identified between them, looking ahead towards towards rebuilding, learning all of the lessons that we have hopefully learned, and new ways of doing things that we've demonstrated. So with that, I think this is a continuing conversation. I appreciate very much each of the inputs and the work and the ideas that you've shared today. Let's continue this conversation as we move forward towards the interfaith meeting that's coming up quickly, but also towards G20 events, which will be looking very much at the rescue packages and at the global governance and coordination issues that have been referred to, but also to the very local dimension that we all know is where things really happen, and where we break down the fences, where we bring the right people to the table, so that their voices are not muffled, so that they are indeed heard. I think those are among the many critical messages that we've learned or heard today. And the recording of this event will be on the Berkley Center website very soon. My colleagues are remarkable in making that available, and we will, I think we have a collective commitment to pursue the conversation. So thank you all so much.